While mitral valve prolapse is generally a benign condition with an excellent overall prognosis, a specific, albeit rare, subset of patients exhibit what is termed the arrhythmic mitral valve prolapse or malignant MVP phenotype. These patients are at a distinctly elevated risk for complex ventricular arrhythmias and sudden cardiac arrest. The 2022 EHRA expert consensus statement provides the current framework for identifying and managing this high-risk cohort. The link between MVP and arrhythmogenesis is primarily mechanical, leading to an acquired structural substrate. The severe systolic billowing of myxomatous leaflets exerts excessive traction on the chordae tendineae and papillary muscles. This chronic localized mechanical stress leads to friction and stretch on the infrabasal left ventricular wall and papillary muscles, causing localized myocardial hypertrophy and eventually replacement fibrosis. This fibrotic substrate alters local conduction properties, creating a nidus for re-entry and triggering premature ventricular contractions. These premature ventricular contractions can initiate polymorphic ventricular tachycardia or ventricular fibrillation, culminating in sudden cardiac arrest. Risk stratification relies on a combination of clinical, electrocardiographic, and multimodality imaging markers. Historically noted more frequently in young to middle-aged females, though sudden cardiac arrest occurs in both sexes. Unexplained syncope is a major red flag and a primary indication for aggressive risk stratification like implantable loop recorder or EP study. T-wave inversions, particularly in the inferior leads 2-3 AVF, reflecting regional stress on the infrabasal wall. Complex ventricular ectopy, frequent PVCs often presenting with RBBB morphology and superior axis, localizing the origin to the posteromedial papillary muscle or the basal infralateral wall. Alternating PVC morphologies like both papillary muscles or outflow tract origin indicate a highly unstable substrate. Transthoracic echocardiography is the first line for identifying high-risk structural features. Bileaflet prolapse, myxomatous degeneration involving both leaflets with significant redundancy. Mitral annular disjunction, a pathological systolic separation between the posterior mitral wall leaflet hinge point and the basal ventricular myocardium. Mitral annular disjunction results in paradoxical systolic expansion of the annulus, exacerbating mechanical stretch. Peakle Hop sign. On tissue Doppler imaging, a high velocity systolic signal as prime 16 cm per second or more at the lateral mitral annulus, reflecting the aggressive traction of the prolapsing leaflets on the annulus. Cardiac magnetic resonance imaging is critical for tissue characterization and is highly recommended for arrhythmogenic mitral valve prolapse risk stratification, especially in patients with complex arrhythmias or severe mitral annular disjunction. Late gadolinium enhancement, the hallmark of malignant phenotype. Focal LGE is typically found in the papillary muscles or the basal infralateral mid-myocardium, confirming the presence of the fibrotic arrhythmogenic substrate. Management shifts from simple surveillance to active intervention when the malignant phenotype is suspected. Extended Holter monitoring like 7 to 14 days or implantable loop recorders are strongly indicated for MVP patients with unexplained syncope or significant palpitations to capture silent, non-sustained ventricular tachycardia. Beta blockers or non-dihydropyridine calcium channel blockers like verapamil are first line for suppressing frequent symptomatic PVCs. Flecainide if no severe structural heart disease, or amiodarone may be considered in refractory cases. Targeted ablation of the papillary muscle or Purkinje network triggers can be highly effective in reducing PVC burden and terminating recurrent VF, though it does not eliminate the need for an ICD if the risk of sudden cardiac arrest remains high. ICD implantation, secondary prevention, class 1 indication for MVP patients who have survived sudden cardiac arrest or sustained hemodynamically untolerated VT. Primary prevention, considered in patients with arrhythmic mitral prolapse, unexplained syncope and high-risk features on CMR like presence of LGE, severe mitral annular disjunction, coupled with complex NSVT on Holter, particularly when EP study is positive, or alternative high-risk criteria are met like left ventricular ejection fraction less than 35%, symptomatic heart failure despite more than 3 months of optimal medical therapy.